but it's a
Yeah.
relapsing remitting condition. And the big fear for these patients is that they don't know when they're going to get it next. And
Mm.
that adds to their quality of life burden, to their fear.
Now a message from Sun Pharmaceuticals. For patients with locally advanced basal cell carcinoma who are not candidates for further surgery or radiation, hedgehog pathway inhibitors offer a targeted systemic approach. Staying current on these therapies can help you expand options for appropriate patients. Welcome to That's Derm Good. Today, my guest is Dr. Naiem Issa. Dr. Naiem Issa is the Medical Director of Clinical Trials and Professor of Dermatology at University of Miami and George Washington University, and also works with Forefront Dermatology. Thank you for joining me.
Hey, Janelle, thank you so much for having me today. Looking forward to our discussion.
Yes, it's great to have you here and chat a little bit about what you're doing in the derm space. So, you are a MD and you have PhD. Share a little bit about that and your path and why you chose dermatology.
Yeah, so interesting. It was a long and unexpected journey, but I never thought I was going to do this path ever in my life. But I started off going to medical school first, and I used to take the summers doing research in computer programming over at the NIH and National Institute of Health, and looking at receptors and how we can model them with computers. And it was a lot of fun for me to be able to do that. And I made some cool discoveries during my first year of medical school, where one of them was that I could predict drugs and what they could bind to using a computer algorithm that I created. So one cool thing that came out from that was there was an old drug called mebendazole, which is a hookworm medication, and I discovered it could be used for cancer. And that was a finding in 2012 that really launched my scientific career. So I remember the dean of the medical school coming up to me at the end of my first year, and he said, "So what do you want to do when you grow up?" And I said, "This is kind of cool, this science stuff." And he said, "Why don't you leave medical school for a while and go get a PhD?" And I said, "Okay." So I took a leave of absence and I went straight to grad school, and I got my PhD in cancer biology and decided to
Wow.
do that, more computational stuff, and that kept building on top of each other. And then went back to medical school, and long and short of it is that I thought I was going to be a surgical oncologist. I was going to do general surgery, have a lab, and all that stuff. But then I discovered dermatology late into my fourth year, and then never looked back. I did a surgical internship, then went to do a postdoc in Miami, and did some other cool things there, and then continued on to dermatology. And now I work with a lab in Miami, and I see clinical patients in dermatology in Northern Virginia here at Forefront, and I get to do all the things. And it was just very unexpected, which was a lot of fun.
Wow. Yeah. So you're staying busy. So George Washington University is in DC, right? Which
That's
is,
right.
I guess, close to Virginia. Okay. And you go to Miami often as well?
Yeah, I do. So I spend a lot of time, first of all, in Northern Virginia, like where the clinic is. And I do go down to Miami every so often to look at things, etc. But I also go all over the country, guest lecture at a lot of universities and different clinics and programs and so on. So catch me if you can.
Right. Staying busy. That's good. So, as far as your work at Forefront Dermatology and connecting with clinical trials and research, how did that kind of fall into place?
I work at a clinic that has a lot of tan walls and old wood, meaning that it was a big medical dermatology place, right?
Mm.
And I just felt so alive because of all of the pathologies, that would come in here, and the need to, treat patients with the newest medications and innovations that we have, but also knowing that there was still so much more to do and finding new innovations. And so I was really intrigued by the potential of at least this clinic to start off, from the grassroots to create clinical trials. And luckily enough, Forefront was very supportive of that and has helped me, get off the ground here. And with a grander vision now of actually being able to start at other clinics throughout the country and hopefully build a powerhouse where should a pharmaceutical company want to do a phase 3 trial and want to integrate with Forefront to get a lot of sites, we're building to that potential.
Mm.
So it has been very fascinating, but it has a lot of growing pains, to say the least.
Yeah. I've always been fascinated by clinical trials. I think I had somebody else on, we were talking a little about those and, just one of the offices that I worked at, they did clinical trials there. I wasn't heavily involved in it, but it was just really interesting to see how they actually work and getting people involved in those trials to, learn about different medications. But what was kind of cool is when they actually work really well and you see these patients come out and
Hmm.
then they get approved. So now you get to see that whole cycle and how it works and changes so many lives. It's actually really amazing.
It is, and actually, what's a real fun thing to see is like when you're not supposed to know what medication a patient is on, but you kind of
But
know
you kind of
because
know.
they're
Hmm.
doing pretty good. It's the coolest feeling in the world, to be honest, because like the innovation working right in front of you. So
Hmm.
it's history.
Yeah. Okay, so tell me a little bit about what you're working on right now. You're doing some trials for CSU, right?
Yeah, so CSU, right? But like, what a comeback, right? So, or chronic spontaneous urticaria. So yes, actually, so right now we're in the process of getting up and ready to do a head-to-head study with the newest small molecule BTK inhibitor on the market called remibrutinib or Rapsido. It's a head-to-head with Dupixent, actually. So two very different mechanisms of actions, and we're going to assess just how quickly can these medications work, and
Mm,
may there be one that's more superior than the other after this head-to-head. And in
yeah.
addition to that, we're doing a real-world study, more like of a registry type of study that we are working with allergists, immunologists as well, and working with Novartis on that. So a lot more data for CSU to come about, and I'm sure we'll talk about a little bit later, just like all the things for CSU and what do
Hmm.
we need to care about.
Yeah. So, okay, tell me a little bit about what a BTK inhibitor is and how it works in plain terms.
Yeah. BTK is not the Burger King, okay? So BTK
Right.
is Bruton's tyrosine kinase, all right? Bruton's tyrosine kinase. So in biology, all right, you have these proteins called kinases, and what they
Mhm.
do is they take signaling from cytokines from above the cell and bring them into the cell, and they interact with each other and crosstalk and all that jazz. So kinases are signaling molecules, right? You
Mhm.
have, geez, like almost maybe 300 plus kinases that we know of. There's so many, and they all kind of act the same, but there's slight differences between them, different pathways. Bruton tyrosine kinase, for the longest time, has been associated with viral infections. It's been
Mm.
associated with like immunodeficiencies when you have a lack of it specifically. And so there was a condition back in the day that we learned about called immunoglobulin deficiency, where you can't make your antibodies because you don't have BTK. It's very important.
Mm.
But specifically with CSU, all right, with chronic spontaneous urticaria, is that Bruton tyrosine kinase is actually found in the mast cell, right? And the mast cell is what releases histamine and these other pro-inflammatory mediators that gives you your hives and angioedema and swelling and and joint pains in these urticaria patients and so on. So BTK is right smack in the center that's integrating all the signals for the mast cell. When the mast cell's going haywire, it always goes through BTK, and BTK says, "All right, mast cell, release the immune stuff. All right, release the histamine, release the cytokines and leukotrienes and whatever." So BTK, in all essence, is that it's a way station
Mm.
for signal.
Okay. When you have patients come in, how did they receive that and how do you
Ah,
talk to
so
patients about that? Is there a need
so
for them
so
to even know it?
actually, I say the answer is yes. All
Mm.
right, and this may be a little bit shocking because you're going to teach some biology, especially kinases, to a patient in a 10-minute visit.
Hmm.
The answer is yes. And I'll tell you what, because you have CSU patients are so frustrated and they're expecting to have a gamut of tests to tell them that the shellfish that they ate from Tuesday is what's giving them their hives on Friday, right?
Hmm.
Interestingly enough, in CSU, the majority of testing turns out to be negative, right? There's actually not a need to go do pre-testing, allergy testing, and all that jazz, because for CSU, you're not going to find a trigger,
Wow.
right? So hence the name spontaneous.
Mm.
All right, so that's the first step. And then what patients know and what clinicians know is that you start off with antihistamines. So you give them, one pill of Zyrtec, maybe you give them one pill of Allegra, maybe do two, you go up to four. And then if that's not working, which I don't expect it to work more than half the time, is because there's more than just histamine in these from these mast cells. Then you start looking at other immune type of treatments. We're talking about steroids, and we also use Xolair, if you've heard of that before. It's
Mm-hmm.
anti-IgE, and the cyclosporin, and so on and so forth. So while some of these treatments are pretty good, the thing is that they're only tackling a single aspect of CSU. So with mast cells, there's two major signaling pathways. You have something called the autoimmune pathway, and you have an autoallergic pathway.
Mm.
The allergic pathway, which is called the type 1 signaling, that's where you have IgE. All right, there's an antibody that reacts with the mast cell. That's an IgE subtype, and then it causes signaling to release histamine and the other pro-inflammatory mediators. That's the majority of patients. But for others, you have the IgG or type 2b autoimmune pathway. And more often than not, you actually see that associated with autoimmune thyroid disease.
Oh, wow.
So that IgG response will never respond to an IgE treatment. So why this is important is because when I talk to my patient, I actually draw a circle for a mast cell on my drawing board, and I show them there's two pathways, two roads leading to Rome, which is the release of histamine and the other mediators. And I show them a circle in the center that shows BTK. And I says, it doesn't matter where you're coming from because all roads lead to BTK. And I believe that using a BTK inhibitor such as remibrutinib should be good for you regardless of where you're coming from. And so that gives them more hope.
Yeah, that makes sense. Do you find that patients are coming to a dermatologist or are they going to see an allergist
Ooh,
first?
that's a great question. So in my neck of the woods, I still think that allergists are the front line for this,
Mhm.
and simply because I think patients don't know that they can see a dermatologist for their hives.
Yeah.
We're very well equipped to understand hives and the background behind it and how to diagnose and so on. But I think the problem before was that we never really had great solutions for treating hives besides what we mentioned before. And now we have dupilumab or Dupixent, which acts in a different way, but also has been recently approved. And now remibrutinib, the BTK. So I
Hmm.
think now there's a greater understanding in dermatology and how to treat, and we are more willing to see these patients than ever before. So I think we're going to wait for the onslaught of patients to come into our doors now.
Yeah. Yeah. I was going to say, what do you think that collaboration looks like? Would a dermatologist ever refer patients to an allergist because you can obviously treat it? Or would an allergist refer to a dermatologist for that? Or would it just be coming from maybe a general practitioner altogether?
Sure. So I think first, access is the number one issue. And so whoever has the space first, the
Mhm.
patient is going to go there no matter what, right? And we have an
Yeah.
access throughout the country. The other part is that does the patient truly have CSU? And so if that patient comes to me first, I need to do the due diligence and get the proper diagnosis. But if it's not a true CSU patient, I'm definitely going to send them to allergy because I'm going to need some help, right?
Hmm.
And same with the allergist. Like we work together, not in silos.
Yeah.
So regardless, like at some point, the majority of these patients may crosstalk between us, and some patients may just ask for testing, no matter what you try to convince them of, right? And these patients be like, well, you know what? I can't believe you're not testing me. I heard that it's because of the tick that bit me. I definitely have alpha gal. I'm like, oh god. So I'm gonna send them to me for the testing anyway.
What kind of testing would you do for CSU? Do you do a biopsy or
No,
how do you even know?
so it's a great question. All right. So first of all, you got to look at the patient, right? And so a hive is a hive. So I think most people can understand what a hive looks like on
Right.
more light skin, like myself. More Caucasian or olive tone skin. But I think hives are actually kind of difficult to discern a more skin of color. So I think some education around that is important because it can be more violaceous or
Mhm.
sometimes even more darker than violaceous. Some things to think about. And then understanding what angioedema looks like, so swelling of the lip, mucosal membranes, and things like that. Also, CSU can have angioedema only. You don't necessarily have to have
Mm.
skin hives findings, by the way. You can just have swelling of the lip or the tongue and what have you. And that's about, gosh, if I remember the numbers right, anywhere between 4 to 6%, or maybe up to 8% of patients with CSU have angioedema only. And about a third have that overlap with angioedema and the hives itself.
Mm.
But by the way, the angioedema with CSU patients is actually not scary. They don't have airway involvement. And that's another
Oh.
reason why dermatologists are now able to get more confident in treating, because if you have a true CSU patient, they're not going to get their airway cut off and have anaphylaxis and things like that.
Oh, wow.
So that's good to know. But so that's just looking at the patient, right? But
Mm-hmm.
then, when it comes to like, okay, do I want to test for some allergens and so on? So now the new guidelines is that you don't need to do that, because you're more often than not, the prick test, for example, you can send an allergist to do a prick test to look for any hives inducing kind of element, any food or whatever. It's probably going to come back negative. More often than not, it is negative. Or patch testing. By the way, patch testing is a completely different mechanism. It's a type 4 cell-mediated immunity kind of reaction. It's not mast cell. So people
Mm.
erroneously may do patch testing, but for what? The immunology doesn't make sense, right? So I don't do any of that.
Yeah.
But the one test I will do is for autoimmune thyroid disease, because there is that 10% of CSU patients that are IgG mediated, or we call the type 2B. And we tend to see that associated with like Hashimoto's or Graves or what have you. So I do test for that. And I do tend to see a positive anti-thyroglobulin or thyroperoxidase, like TPO picture there. And it's good to know, because that actually sets them up for an endocrinologist while I am treating their CSU.
Hmm. Now a message from Sun Pharmaceuticals. For patients with locally advanced basal cell carcinoma who are not candidates for further surgery or radiation, hedgehog pathway inhibitors offer a targeted systemic approach. Staying current on these therapies can help you expand options for appropriate patients. Do you think any of those are, I guess I want to say, comorbidities? Do you tend to see CSU first and then find out
Mm.
later that they have some other issues, or do you find the thyroid issues first and then say, hey, maybe that's something we should look at? And
I think that's also a great question. So I don't know the numbers off the top of my head, but I think there's almost even of one scenario versus the other with the thyroid specifically, all right?
mm,
So with the thyroid, and but I see in my practice that people are coming to me with CSU, and then I find that they have an underlying thyroid condition.
mm,
But that's just me, one person. I'm not representative of the United States.
right.
But that's just what I'm seeing.
Yeah. Just wondering if there were ever anything that patients could look out for or think of, okay, how can I take any preventative measures or
Oh, you
help to
can't.
control? Yeah.
This just has an association. So, for example, if you have a thyroid disease, a thyroid condition, treating the thyroid condition is not necessarily going to actually treat the CSU
Hmm.
or anything else like alopecia areata. We know there's thyroid and alopecia areata. It's the same deal.
Yeah. Hmm. Yeah, that's interesting. So, what do you think is so misunderstood or misdiagnosed when it comes to CSU?
I think most misunderstood is the lab testing, as we just talked about,
Hmm.
and that it's a scary condition. So again, to repeat, you don't get
Mm.
anaphylaxis with CSU. You don't get laryngeal edema or neck edema as part of the angioedema. I think these are the two greatest misconceptions. And then
Mm.
number three, the third misconception is that derms can't treat it, and that's entirely incorrect. We do have the power. We have the understanding of the immunology. We have the tools now, right? We have
Mhm.
omalizumab, we got dupilumab, now we got remibrutinib, all non-steroidal, non-immunosuppressant options that we can use here. So it's no longer a misconception, right? We can treat. We should take it back.
Yeah. Do you feel like a lot of derms have been waiting for this time for more medications like Repsido to come out, just
Yes,
so
I
that they
we
can
we
say, "Hey, I could do this too."
Yeah, so there are. So I think there's a group of clinicians who are like, yes, I've been watching and waiting, and I want this thing, and I
Mhm.
have met them. Like when I helped launch this over at Fall Clinical, it was truly such an awe-inspiring experience to me, because of the number of people that actually came to listen about Rhapsido that day, and this was just in October, and standing room only. People wanted to learn so bad about how to treat CSU with Rhapsido, which was great, and the amount of questions that I got about that. So people wanted to learn. So there's a lot of people who are ready, but then there's another group though that I think that CSU gets in the way of their day-to-day clinical encounters. That it's just too hard, and that they can't move fluidly through their day because CSU is hard. And I
Mhm.
think that group actually stands to really be educated here about actually how easy it is to treat CSU once you understand the disease, and then you can walk through that, in a quick, bullet to bullet, point by point fashion in order to, get to the ultimate treatments, right?
Yeah.
So I think there's two camps.
Yeah. So, what exactly makes Repsido different from the standard treatment options, and how does that work for patients? And what of those results? What are those results that you've been seeing so far?
Right. So with Rapsido, which is also known as remibrutinib, it is the first in class BTK inhibitor in dermatology. It's not the first BTK inhibitor in medicine, but the
Mm.
first in dermatology. It was made to be very specific to BTK, as well as a little bit of the TEC family, which is another set of kinases that are closely related to them. And with the thought process that if you're going to hit, the nexus where all the roads that are leading to Rome, you're hitting them right at that Achilles heel, that it should work for the majority of patients, no matter what they were on before, and if it was type 1 autoallergic or type 2B autoimmune type of disease. And no matter for how long they've had the disease before, because immunology changes over time too. And that's
Hmm.
exactly what was found in the Remix trials, Remix 1 and Remix 2, which are the phase 3 pivotal trials. That led to the efficacy and safety that we know, and the FDA approval here in the United States. And so they have data as early as 2 weeks, post hoc analysis, as early as 2 weeks, looking at a hive severity score and looking at itch severity score. So actually, so just very briefly, for those of you in the audience that are not familiar with the CSU type of endpoints, right? This is actually kind of critical. It's not what we as clinicians think that the patient is doing well based on looking at them. It's quite the opposite. This is what the patients are actually reporting to us. They do these diaries, all right? They do these diaries counting every day the number of hives they get in the morning and in the evening, and they also count an itch score from 0 to 3. And so there's a calculation to tell you the number of hives over the course of 7 days from their diary, and same with the itch score. And that gives you what's called a hive severity score, or HSS 7. And then you have an itch severity score, which is your ISS 7. Then there's a combination. They call it the urticaria activity score, or UAS 7, over the course of 7 days. And
Mm.
the goal is to see how much is the reduction in those scores over time compared to a placebo. So Rhapsody was able to do that better than placebo for all those metrics, itch, hives,
Wow.
and the combination, compared to placebo over the course of 12 weeks. That's where the primary endpoint was. But we have data for week 2, and
Wow.
actually as early as week 1 for some.
Wow. That's amazing.
Because people want to get better faster. So if we were able to
Yeah.
say that, hey, there's a chance in the first 7 to 14 days that you're going to be able to do better with your hives and you're living with this thing for 5 years,
Hmm.
sign me up.
So, a typical CSU patient, because it's spontaneous, that makes me think that it's not on a regular basis. Are they dealing with hives like every single day, or it goes away one day and then it comes back? Like, what does that look like for patients?
So God only knows, right? That's kind of the whole point of the word spontaneous. But it's a
Yeah.
relapsing remitting condition. And the big fear for these patients is that they don't know when they're going to get it next. And
Mm.
that adds to their quality of life burden, to their fear.
Yeah.
So they don't know. We don't know. And does it burn out? Maybe after a couple of years. There's some evidence that after 5 years, for some patients it burns out, but you'll never know
Wow.
until you find out.
Yeah. So, I mean, for my brain, I'm thinking on the access side. So I'm like,
Hmm.
okay, what are some important things that I need to put in or make sure are in the chart notes that insurance is going to
Uh-huh.
be asking for? So you did mention like a tool. Is there a standard scoring tool that you think that insurance companies are specifically looking for? Because I think most of, like for HS, we get the Hurley stage, and then prurigo nodularis, we have to count how many nodules and have like a
Mhm.
certain amount for insurance to approve things. Is there anything specifically that you're seeing for CSU?
Yes, there's a couple of things, and this is very important, Janelle, because this is the way you have to get the access, for Rhapsido. So first and foremost, what you have to do is you have to have moderate to severe disease, right?
Mm.
So, and you do that by just looking at the patient, asking them how they're doing. You also have to have the disease for at least 6 weeks. Okay, at
Mm-hmm.
least 6 weeks to be considered chronic. So you have to have the right diagnosis, and they have to have at least somewhere in the chart that says that they've had the disease for 6 weeks or more. You have to have that documented, all right?
Mm-hmm.
Then these patients have to actually try and fail a second generation H1 antihistamine. And let me repeat that. They have to have failed a second generation H1 antihistamine. It could be a Zyrtec or it could be an Allegra or what have you. Now, it doesn't have to be that they failed up to 4 times the number of pills, for the highest recommended dose. All it says on the package insert is that they have to have failed it.
Mm-hmm.
In my eyes, that could mean anywhere between 2 to 4 weeks because you'll know very early on if the antihistamine is working or not. But I personally and my patients don't necessarily want to wait to kind of ratchet up, antihistamines before switching to Rhapsido, or even not just switching but adding it on. Because in the clinical trials, patients will come in on a failed antihistamine, they stay on the antihistamine while adding the Rhapsido,
Mm-hmm.
right? So these patients have to have a documentation in the chart that they have tried and failed a second generation H1 antihistamine. Without that, you ain't getting the access,
Mm-hmm.
right?
So that's really the only thing that they have to try and fail?
According to the package insert, yes. Now, do I have the magic lens of Blue Cross Blue Shield and
Right.
Aetna and all that stuff? No, but for the most part, the answer is yes. And
Mm-hmm.
let's not forget, because this is a new branded medication systemic on the market. Novartis does have an excellent patient access program to utilize.
Yeah, that makes sense. I mean, I think those programs are definitely helpful because, insurance changes so often,
Mm,
every 6 months or so, we're getting new information to say, oh, you have to do this step therapy requirement. So, that's always an uphill battle. But when they have programs like this in place, that, I think it provides hope to patients because those are the two main questions: is, am my insurance covering it, or how much is it going to cost? So,
right, and the
yeah.
beauty also is that should the clinician think that Rhapsido is actually the medication that the patient should be on, there are samples, and let me tell you, I've been using those samples, and it's pretty incredible because you don't need to do labs for
Mm,
Rhapsido. And so, and unless there's any drug interaction you have to be worried about, so you do an interaction check. There's a segment about warning for bleeding and about liver impairment. I'll just bring that up momentarily. But if you find your patient to be the right patient to be on remibrutinib or Rhapsido, I go and pull it from my cabinet and I say, take the pill now. We don't have to wait for anything. And that starts to give them confidence and they start to feel better while we are working on getting that access for them.
mhm.
And as you probably know, Janelle, is that if your patient's doing well on the drug, you can use that as more ammo. So, like, you do a follow up visit, you do that note, you write the addendum, like, hey, my patient's doing better. They need the
Mhm.
drug, right? So that's why I urge people to actually, clinicians, to utilize those samples whenever they can.
Yeah, absolutely. Okay, did you say it was a oral or an
Or
injectable? It's
oral
oral.
twice per day.
Okay. Yeah, that makes it definitely is important when they come back in for that follow-up to get those notes to show how well they're improving because yeah, insurance is so quick to deny something, especially because it's new or on the market. So if they can get started on therapy, I think the one thing that I've seen is as long as I submit a prior authorization and it's a new start, even
Hmm.
if they've been on samples, then it's a little bit easier versus insurance saying, no, you're trying to establish them on therapy through samples. But there really isn't a lot of, step therapy requirements so far, it sounds like. So it should
Hmm.
be pretty cut and dry, you would think.
Right, right. So far, I would say in my experience, and I'm in Northern Virginia, and
Hmm.
obviously different states have different, the carve outs and what have you. It's been good, but only
Hmm.
time will tell.
Yeah. So let's talk a little bit about the quality of life aspect for patients. What are some of the things that patients have said to you that, maybe they can't do because of this and how it's affecting their day to day?
So I'm going to tell you a case that I had recently that I will never forget. I had a lady in her late 30s. She was previously military and is a nurse practitioner, like right down the street from where I work here, the major hospital system. She saw maybe 10 different clinicians. I'm talking about allergy, immunology. We're talking about, internal medicine, rheumatology, all the works. And then she ended up at my door and then she was like, hey, I hear you think outside the box, and like, I'm almost going to the NIH, but you're going to be my last stop. I don't know what's going on. She's like, I get this weird swelling in my face. I get this weird rash on my butt, and like nobody's making any sense of this. And I'm like, okay, let's take a moment here. So what she was describing is that she had actually angioedema of her face, swelling around her eyes. She gets swelling up the lip and the tongue, but she never had trouble breathing. And she went to the ER numerous times. And her colleagues, they were so scared. They gave her Benadryl, epi shots, epinephrine, stuff that you didn't actually really like need to go that far if you knew it was CSU. The
Mm.
second part is that she also had an overlap of pressure induced hives because she's a runner, and then when she wears the tight clothing or sits on her butt for a long time, she starts to get hives in the pressure induced areas, hence
Mm.
in the groin and the buttock area. But nobody put the two together, interestingly
Wow.
enough. She was on antihistamines, but it didn't fully help her. And I was like, look, I just got this Rhapsido thing, and when I get started on it, like, this is a lot of great data for it. I gave it to her. 1 week later, she gives me a call, and she was like, I can't believe how I feel. And she's like, I
Wow.
also used to get joint pains, and people thought I had lupus, and I don't get joint pains. And then I come to find that there's an angioedema of the joints, and that's easily
Mm.
mistaken for lupus. All right, lupus
Wow.
arthritis and what have you. Literally, after a week, like, this patient's quality of life has changed. She's taking less antihistamines overall, just because the Rhapsody is working so well. And the quality of life, like, she's back at work. She's like more confident at work. She's not going to go to the NIH anymore. Like, it's truly quality of life, just like almost immediate, day and night. I will never forget that case.
Wow. Yeah, I feel like those stories really just put it into perspective and gives you motivation to fight for your next patient.
Mm-hmm. Absolutely.
That's amazing. So, you've talked a little bit about treating the whole person. How does that show up in your practice day to day?
So the whole person, and
Mhm.
we'll put this in quotes, right? So this is a educational and professional mantra that was instilled in me at Georgetown University, where I did medical school. So at Georgetown, the Latin mantra is cura personalis, all right, which is Latin for care for the whole, or looking holistic at your patient. And looking holistically means that you're not just looking at the patient in front of you, you're looking at the environment that they come from, you're looking at their cultural background, you're looking at other things that could be at interplay with your patient. So when I'm looking at my patient, I can't help but look at everything in a holistic manner to see, am I just treating a symptom, or am I really treating the condition and everything that could be causing it as well. And so that's really what it means, and I really credit Georgetown for instilling that, God, nearly 15 years ago.
That's good. I think so many people are on this, not necessarily holistic, but more conscious of, their environment and everything else. So I think a lot of people are going to doctors and they're going to looking for, okay, yes, I want to treat this issue, but I also want to know why I'm having this issue and what I can do to prevent anything else from happening. So I think people are a lot more conscious about that, and it sounds refreshing to come from a doctor when you talk about looking at your environment and looking at everything else that kind of plays into all of that, all those
Yes,
different factors.
that's how people feel heard when that
Hmm.
happens, and then overall
Yeah.
leads to patient satisfaction.
Yeah. So, what excites you the most about the future of dermatology and drug discovery?
Ooh, all right. Really putting me on the spot here. So we've had a lot of biologics come through. We've had JAK inhibitors come through. Now we
Mhm.
have like BTK, which is awesome. But I still think we are like in the midst of some really cool science. And I think two things come to mind. One is that now we're going to have these biologics or antibodies that can target three different cytokines at the same time. They call them
Mm.
trispecifics. We're going to see that in atopic dermatitis, so stay tuned. We're a little ways out for that, but maybe in another year or two, we're going to hear a lot more about that. And then for me personally, very satisfying is this concept called STAT6 degraders or STAT degraders. So when you have JAKs, you have JAK-STAT pathway, JAK-STAT signaling. But nobody ever really talks about what if you can inhibit the STAT rather than the JAK, which is one step further down.
Mm.
So stats are very hard to target with small molecules, right? So they're like very shallow proteins, so it's hard for a drug to come and stick onto them. So there's this methodology, we're using something called degraders, where you don't have to stick that well, but just kind of well. And then the other part of the drug, actually, it's called a warhead. It brings together a protein that tags the protein, which is the stat. It tags it for destruction. So you're
Mm.
getting that signal, and boom, you're targeting it, to torpedo to another protein that's going to slice it up so that it doesn't exist anymore. That's called a degrader, and
Mm.
we see that a lot in oncology. Actually, they have technology. They're called PROTACs, and PROTAC technology first came out of Yale, I think, back in like 2005, 2006, and it is used for prostate cancer, lung cancer. It's really amazing technology, and now we're actually seeing that move into dermatology. In fact, there's this technology is being worked on for androgenetic alopecia, where
Wow.
for the androgen receptor, you're going to try to degrade it and get it out of the way. So there's some really early evidence there in China for that as well. So again, stay tuned for these degraders, right? So I
Yeah.
think that's going to be the new wave, and we'll be here to talk about it.
Yeah, that's exciting. I love your passion and your excitement for it. I could tell you get really into all of this, but for those that are learning, I think it's great to have somebody that's really motivated and is passionate about it to be able to teach them, because that can I can see that rubbing off for sure.
Yeah, well, hopefully now you're going to want to read. Who knows?
Yes, yes, I am. Do you write any articles? Do you publish anything?
Maybe like every month or every 2 months, there's a new article that I publish. I have a big
Mhm.
team of colleagues that I call upon, that we really have a collaborative feel about us. And I have a lot of students from all over the world that work with me, research fellows, so you name it. So when people are motivated, I love to work with them, and we're always publishing. So let's look on PubMed. You'll find a lot of my work and my colleagues' work, and there's always something new.
That's cool. Well, that's exciting. Thank you so much, Dr. Issa, for your time and hanging out with me and chatting. I think this is really cool information to learn about, and look forward to following what you're doing and checking out some of your articles and learning more.
Awesome. And as you say, that's derm good.
Yes.
Thank you so much.
Now a message from Sun Pharmaceuticals. For patients with locally advanced basal cell carcinoma who are not candidates for further surgery or radiation, hedgehog pathway inhibitors offer a targeted systemic approach. Staying current on these therapies can help you expand options for appropriate patients. Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.